If you hear opening snap and mid-diastolic murmur, your diagnosis should be instant. Yes, it is mitral stenosis. I have uploaded the basics of mitral stenosis in my short section. Do watch them. Now let us start with mitral stenosis in detail. Before starting with mitral stenosis, let us learn the mitral valve anatomy. Mitral valve is the valve present between the left atrium and left ventricle. Now, wherein the mitral valve stenosis occurs, the mitral valve is the bicuspid valve, wherein normally it is showing the bicuspid valve when it is closed, and when the valve is open. And when the stenosis occurs, the valve closing and the opening of the valve where the stenosis has occurred. Now let us learn the components of mitral valve, where we have the mitral annulus. We have two mitral leaflets, that is anterior mitral leaflet and posterior mitral leaflet. Then we have subvalvular apparatus, that is the chordae tendineae and the papillary muscles. We have the left ventricular valve and left atrium. The diagram here is like this is the anterior leaflet. This is the posterior one. This is the anterior annulus, posterior annulus, and here we have the chordae tendineae muscles and the papillary muscle attaching the left ventricular valve. Normal mitral valve area is from 4 to 6 cm square, wherein the symptoms are significant from the valve area, where the valve area falls below 1.5 cm square, and the severe stenosis occurs where the valve area falls below 1 cm square. Now let us define the mitral stenosis, wherein the mitral stenosis is defined as narrowing of the mitral valve orifice, which impairs the diastolic filling of the left ventricle. The normal mitral valve area is 4 to 6 cm square. Symptoms typically appear when the valve area falls below 2 cm square and critical stenosis occurs below 1 cm square. It is defined as the narrowing of the mitral valve, that is the bicuspid valve present between left atrium and left ventricle, causing the obstruction of blood from the atrium to the ventricle. It is a global burden. Rheumatic heart disease remains the leading cause worldwide, especially in low and middle income countries. Approximately 40 million people globally are affected by rheumatic heart disease. The most commonest etiology of mitral stenosis is the rheumatic heart disease. Calcific degenerative mitral stenosis is increasingly recognized by elderly population, those with CKD, that is chronic kidney disease, and women are affected 2 to 3 times more frequently than men in rheumatic mitral stenosis. Now let us see the etiological part of the mitral stenosis, where the most common etiology is rheumatic fever. It is a primary culprit of the mitral stenosis, where it accounts for 95% of mitral stenosis globally, caused by molecular mimicry between streptococcal M protein and cardiac tissues, that is myosin, leading to the autoimmune mediated valve damage. The latent period is typically 20 to 40 years after the initial rheumatic episode. Degenerative, that is mitral annular calcification, wherein it is seen in elderly patients and those with CKD or hyperparathyroidism. Calcium deposits in the mitral annulus progressively restricts the leaflet motion and mimicking the rheumatic mitral stenosis only. Now the rare causes are like congenital mitral stenosis, systemic lupus erythematosus, or carcinoid heart disease, and the iatrogenic causes are also seen in the mitral valve stenosis. There are other causes like radiation-induced causes, gout, rheumatic arthritis, etc. Now let us see the pathology behind the mitral stenosis. Most common pathology is of rheumatic inflammation that causes the commissural fusion. Is the most common lesion of mitral valve where the commissures fuse, which causes the thickening and fibrosis of wall leaflets. The wall leaflets thicken and fibrosis of them occur. Next, the calcification where the calcium deposits occur on the leaflets. The fusion and shortening of chordae tendineae muscle and the papillary muscle starts, and thickening of the subvalvular apparatus like the papillary muscles and the other, and it leads to the mitral stenosis. Let us see the pathophysiology. The pressure cascade of the mitral stenosis, where it is a predictable hemodynamic cascade. Obstructed valve creates diastolic pressure gradient between left atrium and left ventricle, initiating the sequence of compensatory and decompensatory changes. The first change is that is a raised left atrium pressure, wherein elevated left atrial pressure causes pulmonary venous hypertension leading to pulmonary edema, and dyspnea occurs along with hemoptysis. Next, we have the pulmonary congestion wherein the interstitial edema and alveolar membrane thickening occurs. Next, we have the valve narrowing wherein the mitral valve narrows, that is the valve present between the left atrium and left ventricle due to the pressure gradient. Then we have the reactive PAH, that is pulmonary atrial hypertension, which leads to the right ventricle hypertrophy and right ventricle failure. Chronic elevation of left atrium pressure leads to left atrium dilation, predisposing to the atrial fibrillation. Over time, pulmonary cascade resistance rises, causing to the reactive pulmonary hypertension, and right-sided heart failure occurs, that is the terminal stage of untreated mitral stenosis. Now let us see the clinical features of the mitral stenosis, that is the symptoms, that is the exertional dyspnea. It is the earliest and most common sign caused by elevated pulmonary venous pressure, limiting to the cardiac output during exercise. Next, we have the fatigue and reduced exercise tolerance. It is due to the low cardiac output. We have hemoptysis, wherein it results due to the rupture of bronchial veins under the high pressure. It may lead to the blood-tinged sputum. Then we have systemic thromboembolism, that is left atrium stasis and atrial fibrillation promotes thrombus formation, and stroke is a feared complication of mitral stenosis. Then we have the physical signs like mitral stasis, that is a malar flush with cyanotic tint is the classical but late sign of mitral stenosis. That is the cyanosis of lips and face occurs, and malar flush is the dusky pink discoloration over the upper cheeks due to the reduced cardiac output and peripheral vasoconstriction. Then we have the elevated jugular venous pressure indicates right heart failure and tricuspid regurgitation. Then we have early irregular pulse, that is the hallmark of the atrial fibrillation. Diastolic thrill is also seen, that is palpable at the apex in severe mitral stenosis. Hepatomegaly and peripheral edema is also seen. It has the signs of the right ventricular failure. Loud S1 due to the forceful closure of still mobile anterior leaflet of the mitral valve causes the loud S1. Let us see the physical examination of mitral stenosis, where we have the opening snap, that is a high-pitched sound occurring between 0.05 to 0.12 seconds after second heart sound, that is S2, caused by sudden tensing of stenotic but still mobile anterior leaflet. The characteristic of it is the shorter the interval between S2 and OS is the more severe the stenosis due to the higher left atrial pressure. Now let us define and characterize the diastolic murmur of the mitral stenosis, wherein we have the mid-diastolic murmur of low pitch rumbling mid-diastolic murmur Best heard at the apex with the bell of stethoscope in the left lateral decubitus position. It has a pre-systolic accentuation. Sinus rhythm is present. If sinus rhythm is present due to atrial contraction, we see the due to the atrial contraction, increasing blood flow across the stenotic wall occurs. Present due to the present in sinus rhythm and absent in the atrial fibrillation. Mnemonic for it is MS is the mid diastolic stenosis, wherein the mid diastolic murmur plus S for snapping open is equal to MS. Remember, murmur begins after the opening snap and has a rumbling quality and best heard at the apex with expiration. Now let us see the investigation part of the mitral stenosis, where we have the gold standard, that is the echocardiography, that is transthoracic echocardiography. Confirms the diagnosis, measures the valve area and the pressure half time or the planimetry, assess the gradient and evaluates the pulmonary artery pressure. Transesophageal echo is used pre-procedure to exclude left atrium thrombus. Then we have chest X-ray, the classic findings like left atrial enlargement, strengthening of the left heart border, and signs of pulmonary venous hypertension, etc. are seen on the chest X-ray. Then we have ECG finding, that is P mitral A. Broad notched P wave on the lead 2 is seen. Indicates left atrial enlargement. Atrial fibrillation is common in advanced disease. Right axis deviation, right hypertrophy suggests pulmonary hypertension. Then we have the diagnostic mnemonic, that is DOR. D stands for dyspnea on exertion. Then we have O, that is the opening snap on auscultation, and R for rheumatic history. R wave, that is atrial fibrillation on ECG. Sorry, the P wave and atrial fibrillation on ECG. Then the cardinal symptom is the dyspnea, wherein the progressive breathlessness due to elevated pulmonary venous pressure occurs. Often the first complaint that brings the patient to the medical attention. Then we have the opening snap, the pathogenomic auscultatory finding, that is a high pitched snap after second heart sound followed by rumbling diastolic murmur, that is the is seen. S2OS interval inversely correlates with the severity, that is the shorter the OS S2 interval is the more severity of the mitral stenosis. Then we have the history of rheumatic fever, most common etiology. On ECG, look for P mitral, right ventricular hypertrophy or atrial fibrillation, all pointing towards the mitral stenosis. The severity grading by Harrison's is given here, that is mild mitral stenosis, wherein the mitral valve area is more than 1.5 centimeters. Moderate, it is between 1 to 1.5 centimeters. Severe, it is below 1.5 centimeters. The mean gradient is more than 10 millimeters of mercury, also indicates severe disease here. Now let us see the treatment part of mitral stenosis, wherein we have the medical management. Then we have percutaneous balloon valvoplasty or PBMC, wherein it says the percutaneous balloon mitral commissurotomy is the perfect term for here. Then we have surgical management. Medical management like diuretics like furosemide for pulmonary congestion and volume overload. Rate control, we will use beta blockers and non-DHP calcium channel blockers to prolong diastole. Anticoagulation like warfarin etc. are given, and antibiotic prophylaxis for rheumatic fever. To avoid the recurrence, we will do benzathine penicillin. Now we have the percutaneous balloon valvoplasty or the percutaneous balloon mitral commissurotomy. It is first line intervention for symptomatic severe mitral stenosis with favorable valve morphology. Performed via transeptal approach using Eno balloon technique. Ideal candidates have pliable and non-calcified valves without significant MR or LA thrombus. Success rate is more than 90% in selected patients. May need to repeat the procedure. And surgical management is the closed or open commissurotomy. It is suitable for anatomy without significant calcification. Then we have mitral valve replacement, wherein mechanical or bioprosthetic valves are used in this procedure. Mechanical valves require lifelong warfarin treatment, and bioprosthetic valves avoid this but have limited durability. Surgery is indicated when mitral valve area is less than 1 centimeter square with NYHA class 3 to 4 symptoms. Now the conclusion of today's mitral stenosis is that key takeaway is mitral stenosis is preventable and treatable disease. With early diagnosis and appropriate intervention and consistent follow-up, patient can achieve excellent long-term outcomes and quality of life. Early detection can save lives. Interprofessional management is essential, and the lifelong monitoring and is required. Thanks for watching. If you have understood today's video, do like, share and subscribe to my channel.